Um, can everyone hear me okay? All right. So going back a long time, the first meeting I ever went to, the first scientific meeting I ever went to was actually in Palo Alto. It wasn't here, though. It was a meeting that Bernie Cohen organized. It was a New York Academy of Sciences meeting called Sensing and Controlling Motion. And that was the first time I met him. And then we interacted over the years, and especially in the last decade of his life, we became pretty close, both professionally and personally. And so I'm very honored to be here to give a talk in his honor. We ended up writing 2 books. We actually wrote 1 book together, the one in the middle, which is called Vestibular Contributions to Health and Disease. And then actually soon after that, we were having a meeting in honor actually for this book, and that's when he got sick and unfortunately passed away. So Michael Strupp is a German vestibular person, and I edited a second book in his honor. I just want to say he's a lovely man, was a lovely man. And in fact, a lot of what I'm talking about, one reason I chose to talk about this topic is that a lot of the work is actually based on his early work. So the work that he did in the 60s, which you'll see in a minute, actually underlies a lot of what we're doing now. So we're really building on the work that he did many years ago. So just a brief overview, excuse me, of what I'd like to talk about. Some of this will be very, very redundant for some of you, but just really briefly what the vestibular system does and what happens when it's damaged. What are the problems that people have? One of the ways of treating damage is the one I'll focus on, which is a vestibular implant, which is basically like a cochlear implant, except it's for the balance system. And then we'll look at the different behaviors that are mediated by the vestibular system. The most obvious ones are the motor behaviors, and particularly eye movements. We spend a lot of time looking at the eye movements, but also balance. And then something that's sort of a more recent thing is how much vestibular function contributes to cognitive processing and whether we can improve cognitive deficits in patients with vestibular damage. So I'd say about 2/3 of this is work that was done in animals, and the last third, particularly the bottom part, is done in humans, which is what we're working on now. So for that part, I'm collaborating with the group at the University of Geneva, which is one of the 2 places in the world doing vestibular implants in humans. I'm going to grab my coffee, actually. Okay. So I know all of you know at some level what the vestibular system does. This is just a very schematic diagram. So basically, you know, the peripheral vestibular system is in the labyrinth, obviously, and it has sensors that respond to rotation of the head, like turning the head. So those are the canals. There are 3 canals. They sense head rotation in all 3 dimensions. And then there are the otolith organs that are a little more complicated because they actually sense gravity, since we're constantly exposed to gravity. And they also sense translation. Translation is like up and down, forward and back movements. So if you're driving and you slam on the brakes, that's an acceleration backwards, or the gas would be forwards. So interestingly, the otoliths, they actually don't separate these 2 things. They combine them. So what they actually sense is the vector sum of these 2 things, which is sometimes called gravital inertial force or gravital inertial acceleration. So the brain ends up getting 2 inputs. It gets the rotation. It gets information about the rotation of the head, which actually isn't a perfect reproduction of that because it really dominates. It's dominated by high frequency responses. And it doesn't do so well with low-frequency responses, mostly because that's how the canals work. And then it gets the second input from the otoliths, which we usually kind of lump together as gravital inertial force. And one of the enigmas, which I'll get to in a few minutes, is how does the brain take these 2 inputs and generate 3 outputs? Because it actually generates 3 estimates of how the head is moving. One of them is how it's rotating, which I'm calling omega, or W, how it's translating, and where gravity is. So it actually takes 2 inputs and comes out with 3 outputs, which seems almost impossible. But there is an explanation for this that I think most people accept these days. So in an overall sense, that's how it works. What happens when it's damaged? Well, the vestibular nuclei in the brainstem really project to 3 locations. They project to the ocular motor nuclei, the ones that move the eyes. So we spend a lot of time looking at eye movements, usually what's called the vestibular-ocular reflex, or VOR. And if it's not working, then when your head's in motion, the images are moving on the back of the retina and you can't see. Things are blurry and sort of bouncy. So we never think about this, of course, because it works normally in most of us. But if you ever think of like what a handheld camera looks like and everything's kind of doing that, that's what the world looks like if you don't have a vestibular system. So visual issues and eye movements. The second thing is it projects down into the spinal cord. So it's really important for balance and for head motion too. If you think, we don't ever think about these things, of course. They're all very subconscious, but just walking around on Earth, gravity is constantly trying to pull us down to the ground. So we're all exposed to this gravitational force, 9.8 meters per second squared, down all the time. So why don't we just crumble to the ground? Well, our bodies are constantly opposing it, but it's not something we think about. It's all done at a very low level. So there's a lot of trunk and limb contractions that are actually mediated by vestibular inputs that keep us from kind of crumbling or falling when we're walking. So balance problems, major issue when there's a vestibular dysfunction. And the last one I was alluding to is there are a lot of inputs to the cerebrum, especially to the hippocampus, which is the part that's involved with spatial orientation and navigation. And this literature is a bit convoluted, but it seems pretty clear that vestibular damage affects how we think. And I'll get into that in more detail, because we don't ever think about that. Those of us who see vestibular patients, a lot of them describe brain fog, which is this very nondescript thing, but there are actually some deficits that you can identify cognitively in people with vestibular dysfunction. The most obvious one is actually navigation, because we use our ability to find our way through like a visual environment using vestibular signals, but even other things. Mostly how we perceive these aren't so surprising actually, how we perceive our own motion and how we perceive the visual space around us. There are a number of deficits that we'll get into. So let's say you have someone with this damage. A lot of times the damage is permanent. You can't reverse it. So what could we do in theory that might help people? Well, what we usually do is physical therapy, of course, which helps. I won't minimize its use. It actually helps a lot in some people, but it's really all that we have to offer these days. So, I could think of three things we could do that, at least in theory, would help. One of them is to basically get the inner ear to work again. So if the damage is in the inner ear and not the eighth nerve, as you all know, I'm sure there's a lot of research on regenerating hair cells. And the literature on that has been a bit spotty about how well it works, and particularly for vestibular function. There was a recent paper, though, that was pretty convincing from Albert Edge's group, where I am, that it seems like it maybe is going to work, but it's always been sort of really iffy. But there is a lot of work that's been going on this, and I know some of this research is being done here as well. So that's one approach. Probably will end up working eventually. It's just taking a lot longer than everyone envisioned. I'll put it that way. The other thing would be, could you make the brain just compensate better? So the signals go into the brain from the inner ear, and the brain manipulates this in a lot of ways, but it's sort of limited in terms of how well it can do it. And we see a lot of people who just don't compensate well, or we think they don't. But the answer to that is that no one knows any way to do this. It's like, yeah, it's a great idea. People always ask about it, but there's nothing really that helps the brain respond better when there's inner ear damage. So that leads us to the third one, which is the vestibular implant, which I'll be talking about. It's very similar to a cochlear implant that all of you are familiar with. So the vestibular implant was actually invented by Dan Murfield about 25 years ago when he was at OHSU. And then he and I moved together at the same time to Mount Sinai, and we started working on this together. So I studied this in animals for about 20 years, and now we're slowly segueing into humans. So the other group that's doing this, which some of you I'm sure know this literature, is Charlie Della Santina at Hopkins. He's published a fair amount about this as well. So we have slightly different approaches about how we're doing this, but these are the two groups, really, us in the Geneva group and Charlie at Hopkins are the groups that are working on this. Only two groups in the whole world. So you can't say this is like overstudied. There's very little interest in it, I'll put it that way. But, those of us who are interested in are sort of pummeling away at it. So the vestibular implant relies on work that Cohen did with his colleagues in the 60s. So he was the first one to show that if you put electrodes into the canals and you provide an electrical current, you could actually generate eye movements that moved in the plane of the canal. So that means like my left lateral canal, if you stimulate it, my eyes go to the right. If it's my right posterior canal, my eyes do that. The motion actually aligns with the canal. And that's actually an observation that all of this work is based on. So he and Suzuki in particular published a number of papers on this. And this is what Dan picked up on in the 90s. And everything that we've done and Charlie's done subsequently are all based on these observations. So we're really, I'd say, standing on his shoulders. If he hadn't initiated this, none of this would be happening, honestly. So just a brief overview of how the implant works. So one thing to mention off the bat is that we focus on the canals because the canals are a lot easier to simulate than the otolith organs. So I think all of you know the vestibular part of the inner ear has two parts. That has the canals that sense rotation, the otolith parts that sense this sort of strange combination of gravity and linear acceleration. But it's more the anatomy. If you look in the top, let's see if this works. Can you see this up there? No. Is this a pointer? Oh, okay. So if you look up here, you'll all recognize this. This is what the ampulla looks like in one of the canals. So there's this kind of gelatinous mass, the cupula, that projects across it, and the hair cells are embedded in it. And the canals are just tubes filled with fluid. So when you turn your head, the bony part of the labyrinth rotates, the fluid tends to lag behind, that bends the cupula, bends the hair cells, sends electrical signals into the brain. The thing that makes this kind of amenable to simulation is that the hair cells are all aligned in terms of sort of their sensitive polarities. So if they go to the left, they all get suppressed. If they go to the right, they all get activated. I mean, granted, there's a lot of heterogeneity. I'm sure it's much more complicated than that. But at least they share that one similar function. So you could envision, like, okay, if you rotate to the left, you just kind of increase the stimulation. Go to the right, you decrease the stimulation. It sort of simulates this. The otolith organs, which are over here, this is just a picture, they're much more complicated. So in particular, the hair cells are not aligned. They have this radial pattern. They reverse at the striola. When you move your head, like if I tilt my head, the hair cells are doing a lot of different things. It's almost impossible to simulate this, although Della Santina is trying. He has a few papers in animals, but almost everybody has decided, let's go for a low-hanging fruit. This isn't working. Low-hanging fruit, if you will, which are the canals. We can kind of simulate the canals. The otoliths are way too complicated. That leads to an interesting question, which is what happens if someone doesn't have any vestibular function and you give them back canal function but not otolith function? Like, what does that do to people? This is still an open question, but you wouldn't expect it to be quite normal because usually they work together. If I tilt my head, the canals are sensing that and the otoliths are sensing it too. All that information is going to the brain. What if you did that and only sent in the canal information? Your brain might get a little, confused, honestly. So how does this work? Well, basically, we put an electrode right up into the ampulla, drill a hole in the canal, basically jam this electrode into the cupula, and then we stimulate electrically there. And we think we're bypassing the hair cells. We're directly stimulating the ampullary nerves. So if you don't have any hair cells, it still works. And we use this, I don't know if I'll go into these details. We use this stimulation pattern. Okay, oops. That's not what I want. Yeah, so we use the simulation pattern, which looks like this. So this is the head velocity. This is the pulse rate from the electrode. And it's mostly linear. So the faster your head goes one way, the faster you stimulate. Go the other way, it slows down. And then it saturates at the two endpoints. So this replicates, what's called rate simulation, basically. Rate modulation, which is how the canals actually work normally. So the size of the pulses doesn't change, but rate changes. So if I had one of these in my left ear and I turn around to the left, the firing rate would go up on the left. The other way would go down. We do this just in one ear. We're not trying to implant both ears. For one reason, we still don't know what one ear does. And secondly, we're hoping that if you take a bilateral and you make them kind of a quasi-unilateral by replacing one ear, maybe they'll be pretty good, because unilaterals do a lot better than bilaterals. It's very nonlinear. I guess it's similar to hearing. You know, if you lose hearing in one ear, you're not that disabled. If you lose it in both ears, it's a huge decrement. And vestibular is similar. If you lose all the function in one ear, you're not normal by any means, but you're pretty good actually. But if you lose them both ears, you're not so good. So we wanted to try to take bilaterals and turn them into unilaterals. And also, maybe someday they'll be bilateral, but we're just focusing on unilaterals. I think I'll skip the bottom plot. That's just showing how the device responds to the dynamics of the head motion, like its frequency dependence. So unless someone's interested in this, you know, we can skip this, the details. So I said back here, you know, we get these three outputs, and omega, or W, since I don't have Greek letters, omega is angular velocity. But how about the other two? All we're doing is generating angular velocity. Like, how helpful is that actually? It might drive the eye movements, but is it really going to make people's balance better? You know, it doesn't seem that likely. Well, it turns out that a lot of work done before us led to this model, which we'll go through very, you know, just a little bit. But it has a few important points. I guess, can you hear me without that thing?
Yeah.
Okay. What's that?
That's so the people on the Zoom can hear.
Okay, so this is the canal, right? And it's sending this signal through the brain, and this is, here they're calling it, whatever that is, an omega. This is angular velocity. But we're interested in this, gravity and linear acceleration. Well, it turns out that there's a lot of evidence that you can actually calculate this from this, which kind of is very counterintuitive because gravity is actually measured by the otolith organs. It's not measured by the canals. So if you give someone a canal input, how could you recreate where gravity is? Well, the way it turns out to work is that what the brain does actually is it integrates the current estimated gravity with the angular rotation. So let me give you an example. If my head's like this and gravity is like here, and let's say I do this. So the brain actually can, by just measuring how my head's turning and integrating that, it can actually calculate how gravity is shifting from there to there. So what makes this somewhat more feasible is that if you have a good three-dimensional, I should mention, angular velocity signal, you can actually probably calculate this. And I'll show you some evidence of that too. So we can get two of these from just putting in a canal input. The one we can't really get is this one. Because this one, you really do need an otolith input, and we don't have an otolith input, so this one's a little funky. I'm not sure what's going on here. We have some experiments suggesting that you're getting some kind of misestimates of this, but mostly you can figure out where gravity is, and gravity is like really important for balance, right? If I'm like tilted, it's more important for my head to know, my brain to know where my head is relative to gravity than it is how it's turning. So recreating gravity is super important, and strangely enough, you can actually do that with canal inputs, or so it seems. So we don't have to go through all the other details, but that's the take-home message. Just canal information is actually enough to estimate where gravity is, I think. So that's all the background. So getting into the behaviors. So let's start with eye movements. We spend a lot of time dealing with eye movements. So these are, we have an animal, this is monkey data. We have an animal sitting in a chair. It's being rotated sinusoidally like that. So that's the head position. And the top one is the normal response. So as you move to the left, the eyes go to the right. It's kind of, that's what the VOR does. The eyes rotate the opposite of the head. And we're just ignoring these little quick things, which are the quick phases. So you can see the slow phase is a sinusoid. And what we did in this animal is we plugged both lateral canals. So we just like drilled into them and inactivated them. And you can see that when you rotate, you get a flat line. You don't get any response, basically. And this is with the implant on it. So you get a response. It's not as big as that response, but you definitely can generate a VOR response using the implant. And this is, again, maybe we'll skip this. This is showing the frequency dependence of these responses. I'll put it this way. They're not as good as normal. So normal, for the size of the responses, that one way at the top, this is what the implant's generating. It sounds big, basically. And this is the time difference between the head motion and the eye motion, or what's called the phase. And this is normal. And it's worse in the implant. So it's not as good by any means, but you can generate something that looks like the same response. And actually, this is just measured in one animal over 130 days. And over time, this is the size of the response, which is called the gain. So you can see, again, I won't go into details, but it's basically trending up. It's getting bigger over time, which implies there's some adaptation going on. Something is driving it to get bigger. Whatever that is, we can argue about, but it's getting bigger over time. So this is sort of this sort of early experiment. This is one axis. We're just rotating in yaw, like so. We're measuring in one axis, and we're doing this for a really long time, like up to a year. So we generate the response. It gets a little bigger. It's kind of similar to normal, but not exactly normal. But if you think about it, if the eyes were doing this, you'd actually reduce how much the images are moving on the retina when you move your head. You actually be able to see better. If we just turn the current up, we can actually make this bigger. Like we're not stuck at this size. We can increase the size of the response and the size of the input, rather, and the responses will get bigger too. Sometimes you get into trouble if you start raising the current, just like cochlear implants, I guess. You get crossover, like you start stimulating other nerves, like the facial nerve, for example. So there are a lot of parameters to tweak, but it seems to basically work. This is an early VOR measurement. This is a more recent one. So this one's actually done in 3 dimensions. So again, we don't have to go through the details, but we're looking at yaw. So those of you who don't done this too well, this is yaw, my head. We're looking at roll, which is this way. And we're looking at pitch, which is this way. Those are the 3 like cardinal axes that the head rotates about. And this is normal. Let's look at this one. This is normal. This is after we ablate unary. This was done with gentamicin, not with plugging. And then this is when we turn it on. And you get a response. If we turn it off, it goes back to 0. And at the end, when we turn it off, it goes back to 0. And some of them are kind of trending up, like this one. Maybe that one. This is time in terms of days. Again, these are very long experiments. This is 200 days of stimulation. So there is a general sense, well, you can generate a three-dimensional response. Because the VOR does work in 3 dimensions. We always think like this way, but there's also this. Although the horizontal is the strongest one, honestly. And there's less evidence, but some evidence that they improve over time. But the bottom line is we can do it in 3 dimensions. So this is something that's a little obscure, but I think is really important. So we looked at what one would call the threshold of the VOR. So the threshold is the smallest head movement where we can generate a compensatory eye movement. So what we do in this experiment is we start with big ones. Like if you go to the left, you see a big one to the right. And then same with the opposite direction. But every time it's correct 3 times in a row, we make it smaller. It's not like an audiogram, actually. I don't know much about audiograms, but we use a 3 down, 1 up. If you get 3 right, it gets smaller. If you get 1 wrong, it gets bigger. You end up converging, actually, on the absolute smallest motion where the eye movement response is appropriate. And that's what one would call the threshold, just like a pure tone threshold, for example. Thresholds are interesting, though, because those of you who deal with hearing a lot more than me know that the thresholds are actually telling you about the signal-to-noise ratio. They're not just telling you how big the input is, they're telling you how big it is relative to the noise that's present. And I don't mean auditory noise, although it could be. I mean neural noise. It's like noise in the nerve, noise in the labyrinth, noise in the brain. So it's actually how big the signal is relative to sort of the background crud in the background. So thresholds are related to signal-to-noise ratio by signal detection theory. Just take my word for it, that's true. So thresholds tell us something really interesting about signal-to-noise. So this plot is showing the size of the response, which is the gain, like how fast the eyes move, versus the threshold. So let's just look at this for a minute. So if you start with a normal animal, Gain is high, 0.8. Perfect gain is 1, so 0.8 is pretty good. Threshold's very low, it's close to 0. So this is good function, right? You have a big response, you just need a little stimulus to elicit it. When you damage both sides, which we call BVH, then you're over here. So the gain goes close to 0, like there's minimal response, and the threshold goes way up, like you need a much bigger stimulus to get a response in the right direction. And this is with the implant on. So just generally, you can see, the gain moves towards normal, and the threshold moves towards normal, but it's kind of in between. It isn't perfect by any means. This is all lumped together, but if you spread it out for the two animals, you actually get something that looks like this. That's actually this data, but it's just the x-axis is like expanded. So the threshold's actually going down over time. So again, this is a long experiment. The one on the right is 200 days of stimulation. So the threshold's getting better over time. And one reason that's interesting is that this has never been described before. Like, there's no evidence that the brain can improve its ability to identify the signal relative to the noise. That's a really hard thing to do. So we're not doing anything special. We're just stimulating the animals being rotated. There are different,
So do the monkeys with the braided hair cells, do they show obvious postural defects, and are these type of defects rescued by the implant?
Sort of. I'm going to get to that in a minute, actually, if you don't mind. So we actually measured a lot of balance things. I wouldn't say they're obvious, though, except they don't jump around the cage quite as much. I mean, I'm not a connoisseur of how monkeys normally move in the cage, but they don't seem to move as much. But we did measure their balance. So that's actually the next thing I'll show you. This is pretty interesting. We're writing this up now because, as far as I know, there's certainly no evidence in the vestibular system, even in normal subjects, that this ever happens. It's kind of important because damage in the inner ear actually lowers the signal-to-noise ratio. There's some evidence that that's actually important for how people function, but you can't raise it. What you can do is amplify the input. If you amplify the input, you increase the signal and the noise, though. Mm-hmm. So they're both going up together. It's really hard to raise the signal without raising the noise. So again, I won't bore you with explanations about why this might be happening, but it is a pretty interesting observation. Yeah, someone had their hand up. Yeah.
So these stimulations, when you did, is it in the dark or?
It's all in the dark.
Yeah. In the dark. But usually, if you do the vestibular stimulation in mice, and do that for a long time, it's usually go down because that's the habituations. So I wonder why these are going up if you do the stimulations.
Yeah, that's not right. It's not habituation, which would be a reduction. Right. If you rotate an animal over and over and over, the responses get smaller, which is habituation. We're not seeing that. Speaking of Bernie Cohn, what he actually did in his studies, which we're also not doing, is he pre-habituated the animal. So he would put the animal on the device and they'd spin it around like a lot. I don't know how many hours or days, but they did that until everything stabilized because they wanted to study pre-habituated animals. Okay. So we are rotating these animals a lot over 100 to 200 days, but we're not actually controlling for that. But you're right, it's opposing what we might expect to see, which is an increase. It's actually, maybe that's not what we're seeing. Maybe we're not seeing a big increase because habituation is kind of driving it down at the same time. Anyway, this is, I think this is really interesting. I don't know if people see this in hearing. I'd be interested to know whether you can improve thresholds with people with cochlear implants, if their pure tone thresholds improve over time. Maybe they do, and it's just an obvious observation. It's never been seen in this system, and it's not really seen in other sensory motor systems either, so it's unusual. And kind of interesting, and there's sort of trivial explanations and interesting explanations, so I'm not sure which one it is yet. So that's all the eye movement part. So now getting to your question. So these were done in monkeys, just so you know. I have some videos of a few rhesus monkeys. So we looked at 3 situations. With people who have severe vestibular damage, there are 3 situations where they really have problems. So one of them is if they can't see and they don't have good proprioceptive signals. So in the clinic, we have people close their eyes and stand on foam. That's a simple way of doing it. So that's actually what this monkey is doing. It can't see anything. It's looking at this kind of black surround. And it's standing on this thick, you can't really see it, it's standing on this thick, mushy foam. But otherwise, we're not stimulating it, we're just letting it stand there. And we're looking at how much it sways. And this was our first attempt at this, and we tried different conditions like wide stance, narrow stance, thin foam, thick, mushy foam. And this is the sway. These are the normal and the bilaterals. And bilaterals sway more than the normals, especially when you get to the harder conditions, like when you put them on the foam. We tried the implant with the most difficult condition, and it didn't do anything. So, when the monkey's standing there not moving, and you have a vestibular implant on and a bilateral vestibular monkey, they're not any more stable. So, that was sort of a negative response, obviously. But, one obvious explanation would be, when you're standing still, your head's not moving very much. And we're just measuring angular head velocity. So if your head's hardly moving, we're not going to be measuring anything. We're not going to be stimulating. Maybe it's not supposed to help. But I don't know. It just didn't. Truth is, it didn't help. But the head wasn't moving a lot. So that was our most trivial. There's a video, too, if anyone wants to see what the monkey looks like standing there. So it has a water system that's mounted on its head, actually, so it doesn't have any external cues to help it keep its balance. It's just standing there. It's not very exciting. Yeah. So, I don't know. And we're measuring, we have sensors on its head and on its trunk. It's not doing much. So we looked at the other two situations where it's really hard for people with vestibular damage. One of them is when the surface you're standing on is moving. So most of us don't experience it all that much. But if you're like where I am, if you're on the T, you're getting jostled around a lot, or on the train, or on anything that's moving under you, it's very hard to stabilize your balance. So we use this complicated paradigm that Bob Paterko developed, where the platform moves. And this is how much it's tilting, and this is time. So it has this very particular wide frequency range, which is called a PRTS, pseudo-random ternary sequence. So it's doing all this kind of semi-random motion. And then we measure how much the trunk is moving, which is this one. Let me just show you what it looks like. So this was hard to do, to get a monkey to stand on a platform that's moving underneath it. And it's tilting and roll. It's tilting in this axis. So you can see this is following that pattern, and we're measuring how much the trunk is moving. That's what it looks like. That was a very difficult experiment, to just get a monkey to stand there and not leap off the thing. Anytime someone closed their door outside or something. Anyway, so what we found with this was I have to say, in this experiment, we weren't able to test the implant for a variety of reasons, but we compared normal and bilateral. So what we're plotting here is how much the trunk is swaying versus how big the tilt is. So the peak to peak, which goes between 0 and 8 degrees. So the actual platform is this line. So then that's obviously the more it's tilting, the more it's tilting. It's a straight line. This is what normals look like. They actually start tilting like the platform. They follow the platform. So they're aligning themselves with the platform. But as it gets bigger, they stop. They start to actually deviate and start to align themselves more with upright. So the way that this was interpreted by Paterka and others is they're using essentially a proprioceptive thing. They're keeping their ankle joints the same. But when it starts getting too big, they start to align with gravity, which means shifting from following this to orienting more towards upright. And these are bilateral patients. They sort of start the same way. They, let's see. Oh, I'm sorry, I have it backwards. These are normals. I wonder if it didn't make sense. These are normals. These are the bilaterals. The bilaterals don't do it as well. They kind of keep following the platform. They're not as good as aligning their balance with gravity. So there's some deficit. This is just a fancy frequency dependence analysis, which I won't waste the time going through. But the bottom line here, sorry I got this backwards, is normals do this where they start to align with gravity, meaning they're not tilting as much. Bilaterals don't do that as well. Probably because they're not able to figure out where gravity is. So this is number 2 for balance. I better hurry up, actually. I want to get to the cognitive part here. The last one we did are head turns. So, when you see a vestibular patient, a lot of times they say when they turn their head, it throws them off balance. Probably because you're activating the inner ear. Right? If my left ear is not working, I turn my head to the right, my brain's getting a crappy signal. It's going to make me unsteady. So we trained animals actually to look at 2 targets. And to cut to the chase, with the bilateral animal, when they would turn their head, which are all these things that you can ignore, the trunk was rolling actually. It was tilting a lot. And with the implant on, it tilted a lot less. These are just the numbers showing how fast the tilt is and how big it is. I'm sorry, how big it is and how fast it is. These are bilaterals. This is with it on. So they actually stabilized their trunk. So they could turn their head. They were doing it sort of obliquely, and they swayed less. So when we actually tried to parse out postural control, 2 of them we have implant information, this one and the first one, and the second one, for technical reasons, we weren't able to actually test the implant, which was a real shame, because it was actually designed to do that. So we better move on. Last part, cognitive behaviors. So the way this developed is I got interested in the first one, spatial orientation, which is how we sort of perceive our orientation relative to gravity. Like, how do we know how, in the vestibular world, like, how do we know if we're upright or tilted? And that led me to become interested in navigation, which, as most of you know, is finding your way through some environment towards a desired endpoint. And then I thought, well, we're doing let's just look at other cognitive functions too. I'm actually not going to talk about this one because it's just too confusing, but we'll talk about these top 3. So, spatial orientation, we have really nice data in monkeys. So we spent a lot of time training a monkey to do a subjective visual vertical. So most of you probably know what this is, but basically you see a bar and you have a little input device, in this case it's the steering wheel. And when you rotate the wheel input device, it rotates the bar. And we actually train the animals to try to align the bar with the direction of gravity, which is, like if you do a subjective visual vertical test, you put the person in the same situation with like no visual cues, and you say, align this bar so you think it's upright. And if they're normal, they're really good at it. And if they have a lesion, like on the left, they're going to do this. So this was our task to try to figure out how the animals could figure out where upright is. And this is actually showing, this is data from an animal showing how they did this. And this thing was, I should point out, this is being tilted. It's not upright. It's actually doing this. So the chair that they're sitting in is like rocking all over the place, and they're still trying to put this upright. And we're actually making it really hard, too, because the bar is constantly being driven away from upright by noise. And even when they turn it, it like overshoots. So they have to constantly try to get it right. So one thing was actually to answer this question that I posed at the beginning, which is if you activate the canals, does it change how you perceive upright? So you remember I said at the beginning, there's all this evidence that if you integrate the canal input, it actually changes where you think gravity is. So no one's actually really tested this. So we decided, well, let's test it, and also it will be helpful with implant if we can actually show that this works. So this is my my fabulous cartoon. So the animal's upright. Here's gravity. It's straight down, obviously. We're stimulating, in this case, the right posterior canal, which would get activated if you tilted your head this way. So if you tilt your head this way, gravity's now should be coming out of here. If you actually tilt your head, right? If your head think of it upright, gravity is coming out of your right cheek. It should be over here. So if you're trying to align this bar with gravity, you should actually put it over here, because you're no longer doing that. So what we found briefly is, yeah, this actually happens. When you turn on the stimulation, this bar deviates where they're placing it, and the more you stimulate, the more it deviates. So this is 60 pulses per second, this is 200. And we measured some confounding things like what the eyes are doing, because the eyes actually turn when you do this too. So we wanted to make sure it wasn't visual. But this actually shows pretty convincingly that just activating a canal changes how you perceive upright, which is a big, which was a point of contention for a long time. But it's important for this in particular. So this was our short-term experiment. And then we got to this extremely long experiment. This was a really difficult experiment that took 5 years. So what is this? Well, so we took monkeys and we put them in this chair, and the chair tilted and roll, and we either did it sinusoidally or we did it like pseudo-randomly. And we had them with the bar, and they were trying to keep the bar upright while they're being tilted. So we did it in normal animals, which is the top, just to look at it. So the gray line, which looks like a sine wave, that's how it's being tilted. This is a sinusoidal stimulus. And the black lines are the animal's perception of tilt. So they're actually doing a pretty good job. When you tilt them there, they kind of realize they're tilting that way. This is after they were ablated. And this is with the prosthesis on. So you can see between ablated and on, they actually improved a decent amount. So if you look at that in more detail, that one shows the gain, which is how big the animal's perception of tilt is relative to how big the tilt actually is. So if you tilt 10 degrees and you perceive 5 degrees, it's 0.5. It's half the amount. So these are two animals. These were using sinusoids. This shows how the perceived tilt dropped between the normal and the bilaterals. It depended on the frequency, but it was clearly lower after they were ablated. But then the main take-home message is when we stimulated, this is simply showing the change from the stimulation. So positive means you're getting better. And they get better, especially when we used a pseudo-random stimulus, because we thought maybe there was some prediction going on, because it's really repetitive. There's a pretty significant enlargement. So again, an increase of 0.2 is a lot. Anyway, so this seemed to work, actually. The animals seemed to perceive where gravity was better, even though they were ablated. Step one was, can they do it normally? Yes. Does it get worse when you ablate them? Yeah. What happens when you turn this prosthesis on? It gets better. They can perceive where gravity is better. Because remember, balances is a lot of balance is aligning your body with gravity. Like, how do we keep our balance? Well, we want to know where gravity is. We want to align our head and trunk with it. So this is like very important for the development of this as a potential treatment. Okay, we're almost done. So then I got interested in navigation. So not knowing much about navigation, and after trying a lot of things that didn't work, we ended up using a very simple paradigm, which is sometimes called a complete the triangle paradigm. So the way that works is you start at some point, you see a platform go on, you walk to the platform, goes off, you see a second platform go on, you walk to that one, that goes off, and then with no other visual cues, you're supposed to return to where you started. So mice do this unbelievably well. People aren't so good at it, but mice do this brilliantly. So we measured like how big their error was, like how big was the angular error, like if they were out there, that's the angular error, and how big was their linear error. So if they ended here, this is how far they didn't go distance-wise. And we did this two ways at the beginning. So one way, you're actually sitting in a platform, you're using like a little input device, like an Xbox device, and you're looking at a virtual reality image. I guess let me show you what it looks like first. So I happen to have this video. So this is what it looks like for someone doing this. They see this very stripped down visual environment. You hardly see anything. So you see the first target, you move towards it, and then you're going to see the second target, and you move towards that. And then when you get to that, that goes off, and now you have to try to go back to where you started. This is really hard, and maybe I'm just terrible at it. I don't know which it is, because I like to be so bad at this. Mice have this thing called dead reckoning, where they actually can go right back to where they started. I think they're much more dependent on vestibular and less on visual than primates. So that's what it looks like. So one device was you simply aren't moving. In fact, most of the literature on this was based on that, because people are always trying to find things you can do in an fMRI scanner. So you can't move around. So the biggest paper on this was by Thomas Brandt in Germany, where they used this device, head still, using an input device. It's really a visual test, because there's no dynamic vestibular input. So we also did this sort of in-betweener test, where the person stands on a platform with the goggles on, they're seeing the same environment, and the way they move is that when they turn, it turns them within the maze. So they're actually kind of vertical rotational cues. But we wanted to make it easy so they wouldn't fall over. So they have like a surround to hold on to. So the way they translate is they walk in place. So their head's going up and down, but it's not going forward. So the limitation of this test is your head's not accelerating this way, which is the x-axis, but it's doing this, and it's turning. So I was always interested mostly in turning because eventually, at the end of the day, we're interested in prostheses, canal prostheses, which are based on turning. So we compared these two in a bunch of people. And let me just show you what we found here. So these are just some examples, which we'll skip over. But let me just show you one thing. So here's an example. You're starting there. You see that one. You see that one. You try to go back to there. And all the gray ones are all the different trials. And the dark one is the average. So we measured two things here. One was how big the error was. Like how far away were you from that? Like how accurate were you? And the other one is how variable was it? Like, so the variability is sometimes called the precision. Like how much variability was there? Well, this person's pretty variable even though they're pretty accurate. So what we found when we analyzed it is that the accuracy data didn't really show a lot, but the variability or precision data was pretty cool. So that's why I'm just going to show you this for the sake of time. So, so this is the static test. This is the one where you're just using the joy buttons. And these are normals and these are bilaterals. We're looking at the standard deviation of the error. In other words, bigger is worse. It means you're more variable. So what we found is that the bilaterals are a lot better, actually, than the normals. Like their ability to vision seems like highly improved relative to the bilaterals. On the other hand, if you had them moving, when you were getting vestibular but also proprioceptive and efferent information, the bilaterals were worse than the normals. So there's this interesting pattern where it's like the bilaterals seem to be optimizing vision, but if you throw in really garbagey vestibular cues, it seems to kind of override it and you get worse. And the other thing, these are within tests, the static and the dynamic. If you look across tests, if you look at the normals, this is their variability on the static one. If you give them all the other information, they get better. The variability goes down. You do what you'd expect. But interestingly, the bilaterals, when you give them the other information, it goes up. Again, I think the bad vestibular seems to be dominating. So this is normal versus bilateral. So we did measure one person in Geneva with the implant to do this same thing. And this is what we found. So this is before we stimulated them. VI means vestibular implant. This is while they were being stimulated, and this is at a later date after they were stimulated. And we're looking at all four of these measures, actually. The angular error, the standard deviation of the error, and for both conditions, the static and dynamic. And the short version is, if we look at the standard deviation, it went down while it was on, and it went off, it went up. So it seems like it got better, and it didn't get better just because they were learning to do it better, because it went back to where it was. If you look at the other condition, same thing happened. Went down and went up. So the variability ones seem like they really are dependent on the implant in terms of they improve during the stimulation, they get worse after. The other two, the error ones, are a little more kind of funky looking. So this one, which is the size of the error, it went down, but when it was turned off, it went up. It didn't go all the way back up to where it started, which makes you think that maybe there was some learning involved, actually. It was a combination of the implant and the learning, because they were just better at it than they were before. And the same thing here, where it went way down, and then it went up some. So, the variability ones, which are the dashed lines, those are sort of more clear-cut, that we're improving how people can find their way through space using this. The accuracy ones are a mixed bag. There's probably some learning going on, too. Because it is complicated. If you just do this over and over, you get better at it. Like a lot of cognitive tests, so this is really hard to control for learning effects. So we're trying to do that as much as we can.
So with your cohort, is there a lot of variability between the patients with the bilateral?
No, they're all about the same, actually. So we're looking at people who
they
really...
lost their vestibular function for the same amount of time.
Yeah, basically. I mean, they all have essentially no vestibular function. I don't think we can control carefully for how long it had been lost, except that it wasn't recent. It was at least a year ago. So it might have varied in terms of the duration. That's a good question. I should look at that. And I guess the very last thing, because we're running out of time, is neuropsych stuff. I'll just skip over that. This is the effect of the implant. So we did this visual memory test called the Corsi block test that some of you might know, where you see these blocks appear on a screen and then you have to reproduce the same pattern. So bottom line is, with stimulation they get better, turned it off, they got worse. This is a visual spatial memory test. These are slightly more bizarre tests that a guy named Fred Mast in Switzerland invented, where you have to look at the person, and they're shown in different orientations, and you have to indicate which arm is sticking out. So like here, it's kind of obvious. This is the right. This one, it's maybe a little less obvious. It's the right. But that's to like flip them on their side and upside down, which makes it really hard. So bottom line, we don't have to go through the data really. Bottom line is people got better with the implant. Let's look at this example. This is the person's upright. They're turned on their side. They're upside down. I mean the picture, not the actual person. So so the before, like people get a lot worse when it's upside down. It must be really hard upside down. This is the accuracy. When it was on, the accuracy went up, especially for the most difficult condition. And then when we turned it off, it sort of stayed up a little bit for the easy ones, but it got much worse for the hard ones. So this is, again, a visual. This is considered actually a mental rotation test, because the way that they think this works is you actually look at the image, you rotate it in your mind, and that's how you determine. I don't know if this is true. I'm not a psychologist, but that's how you figure out which arm is up. So they can. So this is presumably very dependent on vestibular function. Really rotate the images mentally. And I guess the very last word is, the Corsi is a visual test. Just for interest, we compare it to an auditory test, which is just a digit span, where you just do the same test basically, but instead of looking at something, you're hearing it. So you'll probably know what a digit span is. You read a series of numbers, and you ask the person to repeat them, either forward or backward. And that was normal in the vestibular patients, where the visual one was abnormal in the vestibular patients. So it seems very visual. So, that may be sort of obvious, but there's actually a whole literature of people claiming that vestibular damage affects every cognitive function. And our data is that's not true. There's a lot of arguments about this. Depends partially on how you do it. But we're finding it's really visual and spatial and not auditory, not executive function, not all these other millions of things that neuropsychologists like to measure. Although so this is believe it or not, this is all our preliminary data. This is all the data that we did to get a grant, which was just funded. And then it was taken away by the government. We'll get into that for 2 months. And then we managed to get it back. It was taken away because we have a group in Geneva that we're working with, so you can't have foreign subcontractors. But we managed to circumvent that, so now we can work on it again. So now we're doing a much more detailed version of this. This was our first pass. But it was enough to be, we published a few of these, and it's enough to be reasonably convincing, I'd say. But we're going to try to cross all the T's now and do a more thorough job. And that's it. Thank you. These are all my collaborators. Thanks.
So are the patients with the implants, are they really happy to have them? They don't want you to turn them off?
Usually. Yeah, that's a general observation. Their quality of life metrics are better with it on. So people do like them. Just sort of subjectively, they feel better. Yeah.
How does your approach differ from Charlie's?
A lot.
A lot, yeah.
So, yeah, great question. So, firstly, the patient. Charlie's implanting people with, he's looking at people with bilateral loss, but they can have normal hearing. Unfortunately, people are losing hearing when he does the implant, but they can have normal hearing. The Geneva group, to facilitate this with the IRB, they're only implanting people who are deaf, who are getting cochlear implants already. So they put the vestibular implants in at the same time. So that's one difference. The people we tested in Geneva, which again is a relatively small part of this, they're actually deaf with cochlear implants. Second thing is Charlie turns the vestibular implant on for months and months and even a year or two at this point. The Geneva group turns them on for shorter periods of time because they're not technically as advanced. So they turn it on for maybe weeks. So Charlie's group is way ahead of them technically. The third and final thing is we're focused, at least I'm focused more sort of on this trying to understand what's going on scientifically or in the brain, although obviously the translational part's really important. The group in Geneva and Charlie are focused very much on making this a clinically viable thing that they can get FDA approval for. So there's nothing wrong with that. I'm not being critical. It's just a different approach. His eye is definitely on that ball, getting FDA approval, and getting Medicare approval eventually, so we can start offering these. And you guys, once they're approved, you guys could do them too if you had any interest. Right now, he's locked into an FDA IDE. So the other approach differs, sort of conceptually and also technically. But they're the only ones in the world doing this. Yeah.
I want to get in the weeds a little bit. Could you go back to your slide where you showed the rotation and then the change in firing? I think it's about 4 slides back. This one, yeah. So so clearly you're getting improvements, but they don't quite match the size of that you see with the normal function. And so, I think in the cochlear implant world, the individuals who get an implant, they clearly have changes in loudness growth, but it's not like that in normal hearing, and that's in part just because you're stimulating these individual nerve fibers that really only have a dynamic range of about like 30, 40 dB, as opposed to like the 100, 120 dB that we have. And so when I see here you're getting it's kind of like that same kind of muted function theoretically. So do you think it's a limitation of the encoding within the nerve itself, or do you think that there's other ablations than just the fact that your implant is stimulating one part and there's other damage, and that's why you can't get a full compensation?
Yeah, I think it's more the former.
Yeah.
I think, I think of what we're providing as sort of a cartoon of what's actually normally happening, because all the afferents seem to be being activated together, so they're all entrained. We're probably entraining the noise between them. I don't think we're losing a lot of the subtlety, I'll put it that way.
Right.
So I think cochlear implants might be similar. I think we're putting in a facsimile of a normal implant, but it's not. And we tried to change this a little bit, like synchronizing the afferents using various approaches like background noise or high-frequency stimulation, and we didn't really manage to get that to work better. So I think it's more of a technical limitation, honestly.
Okay.
I think. But I'm not sure.
Appreciate it.
Yeah.
So in the slide where you showed that you can mimic a natural eye movement, sinusoidal eye movement by stimulating the implant, did you have to use any specific patterns of stimulations or any kind of stimulations in the implant would do that?
Well, let me just go back to the one you're talking about. Is this the one you're talking about?
No, the very first slide where you have showed the sinusoidal eye movement.
Oh, okay, sorry. Here,
Yeah.
right? Yeah, no, you can do it. I mean, you can do it in different ways. All you have to do is modulate the strength of this. I think modulate the strength of the stimulation. The strength is the rate versus the amplitude. The amplitude is the current, and the rate is how frequent they are. So the Geneva group is actually modulating the rate. I'm sorry, the current. The way the ear normally works is it modulates the rate. So most people are focused on that. And some people have tried combining them, like making non-physiologic rate amplitude combos. So yes, you can change how the response is depending on what you're putting in. We just use the simple rate modulation where the stimulation rate goes up and it goes down. There's nothing special about that except it recapitulates sort of normal function.
Well, thank you so much.
Thank you.
It's been a treat.